Hi, my name is Atif Darwish, Professor of OBGYN at Asut University, Egypt. Today I'd like to discuss with you an important clinical topic of adolescent polycystic ovarian disease, which is faced by many of us during clinical practice. Firstly, you have to know that the WHO defined adolescence as the period between 10 and 19 years of age. And we have to realize that gynecologic age is the age after menarche. These are very important items because we will use them during this lecture. The topic of adolescent PCO is controversial and challenging because of similarity and overlap of normal pubertal physiologic change and the typical adult polycystic ovarian disease diagnostic criteria regarding irregular menstrual cycles, acne, and morphologic appearance by ultrasonography. The Joint ISHRI and SRM recommendations defined the diagnostic criteria for PCO as irregular cycles and ovulatory dysfunction, clinical and biochemical hyperandrogenemia, in addition to abnormal morphologic appearance by ultrasonography. So the topic of adolescent PCO is challenging because many cases are missed from physicians or gynecologists because they underestimate the occurrence of PCO in this age group. On the other hand, many cases were exposed to treatment, aggressive medications without any indication, simply because this is a physiologic change in the age group of pubertal females. So underdiagnosis, overdiagnosis, delayed diagnosis, or poor diagnosis are common challenging issues of this disease, and the use of inconsistent non-evidence-based approaches in the diagnosis and management is another challenging point of the PCO. If we look to the Joint SRM and ISHRI recommendations, you will find irregular cycles in the salient presentation of women with PCO. But regarding adolescent PCO, they mention that the first year after menarche is considered normal whenever abnormalities of the menstrual cycle. So if the patient is presenting in the first year after menarche and with abnormal menstruation in the form of periods of amenorrhea, menorrhagia, and so you have to assure the patient and her parents that this is normal in the first year after menarche. But more than 1 year, if the patient presents with amenorrhea of 3 months, this should raise the possibility of PCO. And between 1 to 3 years after menarche, if the menses is less than is hypomenorrheic or oligomenorrheic at the same time, or polymenorrheic. So oligomenorrhea means the menstruation comes after more than 45 days, and polymenorrhea when it comes every 3 weeks or less. This is considered or raising the possibility of PCO in this age group. And more than 3 years after menarche, which is 3 years gynecologic age, until perimenopause, if the patient has polymenorrhea or oligomenorrhea or 8 cycles per year, this means that the case should be considered as PCO, provided other criteria are present, including hyperandrogenism and morphologic appearance by ultrasonography. And lastly, they mention that primary amenorrhea is considered a symptom suggestive of PCO when it occurs by the age of 15 or more than 3 years post-cellularity. This is a case of primary amenorrhea, raising the diagnosis of PCO. We don't have to rely on the menstrual abnormalities as a diagnostic issue of PCO, and many females in this age group of adolescency presenting with menstrual abnormalities should be assured with re-evaluation within 3 years post-menarche, which is 3 years gynecologic age. The second item to diagnose adolescent PCO, in addition to irregularities of the cycle, is hyperandrogenism. And the hyperandrogenism is clinically defined as hirsutism, severe acne, or baldness, in addition to biochemical hyperandrogenemia as confirmed by validated high-quality assays. And actually, for the adolescent PCO, the biochemical hyperandrogenemia is more specific than clinical hyperandrogenemia. It is well known that hyperandrogenism in the patients with PCO is due to increased testosterone and decreased sex hormone binding globulin as a part of the physiologic or pathophysiologic change of PCO. Regarding clinical hyperandrogenism, 70 to 80% of PCO women exhibiting clinical manifestations of hyperandrogenism, including acne, which is an inflammatory disease of the sebaceous glands characterized by comedones and pimples, especially on the face, back, chest, and in severe cases by cysts and nodules resulting in scarring, hirsutism, and or alopecia. All these criteria could be seen in adolescent PCO in an aggressive and severe manner. We have to differentiate between hirsutism and hypertrichosis. Hirsutism occurs in females only, while hypertrichosis can occur in males and females. And hirsutism means the occurrence of excessive hair in the androgen sensitive hair areas of the body, while hypertrichosis is excessive hair in normally exposed or expected areas of hair in the body where fine or lanugo hair is changed into thick and permanent hair. As I told you, biochemical hyperandrogenism is more important than clinical hyperandrogenism. That's why the ISGI SRM, ISHRI SRM classification put it before clinical hyperandrogenism as a good diagnostic criterion for PCO. And hyperandrogenism in this disease of PCO is due to excessive testosterone, and testosterone is measured by calculated free testosterone, free androgen index, or calculated bioavailable testosterone. The free testosterone is not synonymous to unbound free fraction of testosterone, because unbound free fraction of testosterone represents only 2 to 3% of testosterone, and we have to join this measurement of unbound fraction of testosterone to the lightly pounded part of testosterone to the albumin, which is weakly pounded, and this is non-specific protein. So free testosterone is a combination of the unbound free fraction of testosterone representing 2 to 3% of testosterone in the serum and the albumin-bound testosterone, and this is called free testosterone. And here comes a great mistake of many doctors, that they rely on total testosterone measurement as a criterion for diagnosing hyperandrogenism, because the total is mainly due to the bound biologically inactive testosterone bound to the proteins, which is called sex hormone binding globulin. Due to the importance of diagnosing hyperandrogenemia by the lab, the SRM and ISHRI recommendations mentions that high quality assays should be used, like immunoassays or chromatography, while the ELISA or direct free assays are not recommended due to poor sensitivity, accuracy, and precision. Some doctors order for androstenedione and dihydroepiandrosterone sulfate, which is not mentioned to be essential for diagnosing hyperandrogenemia, as the recommendations mentioned that it has limited additional information and only relied if the total or free testosterone are not elevated, while the clinical and morphological appearance of the case goes with the diagnosis of PCO. Hyperandrogenemia in patients with PCO results from neuroendocrinal disturbances in the form of increased ovarian and suprarenal androgens, disturbed hypothalamo-pituitary ovarian axis, and hyperinsulinemia, in addition to some genetic, lifestyle, and environmental factors. Neuroendocrinal disturbances in patients with PCO include impaired GnRH secretion with preferential increased LH secretion more than FSH in those cases. A primary enzymatic default in the ovarian and or adrenal steroidogenesis is the main cause of the increased androgen secretion, as the theca cells overexpress most steroidogenic enzymes, particularly cytochrome P450C17 enzyme. As I told you, 3 endocrinal disturbances occur in the PCO: increased LH FSH ratio, increased testosterone, decreased sex hormone binding globulin, and increased insulin resistance with increased insulin level and decreased glucose tolerance. And insulin resistance and pancreatic beta cell dysfunction is a common finding in PCO patients, and this will lead to compensatory hyperinsulinemia due to this resistance, and theca cells will increase androgen senses and lead to stimulation of pituitary to increase gonadotropins, liver to decrease sex hormone binding globulin to increase bioavailable androgens, and the resultant will be hyperandrogenemia. So hyperandrogenemia is caused by insulin resistance, and this is a compensatory insulin resistance due to pancreatic beta cell dysfunction in the PCO patients. At the same time, the patients with PCO express dysglycemia, so 2 times increased risk for type 2 diabetes mellitus. So, defining and well diagnosis of hyperandrogenism is one of the keys of success to properly diagnose a case of PCO, as hyperandrogenism is responsible for the dermatologic changes including hirsutism, baldness, acne or acanthosis nigricans, increased LH FSH ratio leading to anovulation or oligo or hypo or amenorrhea, and pregnancy loss and infertility, increased lipids in the serum, metabolic syndrome, insulin resistance, diabetes mellitus, and increased cardiovascular risk. So we have to stress on how to properly diagnose hyperandrogenism and how to measure the free testosterone in a good way. In addition to the irregular cycles and ovarian dysfunction, clinical and biochemical hyperandrogenism, the ASRM ISHRI joint recommendations mention that we have to revise the ultrasound criteria for diagnosing the PCO morphology. Importantly, they mention that if you see PCO morphology by ultrasonography in a patient who is less than 8 years gynecologic age, which means 8 years after menarche, the ultrasound should not be used for the diagnosis of PCO, and you should not tell the patient that you are a PCO patient because you are within 8 years after menarche, due to the high incidence of multifollicular ovaries in this age group. But if the patient is more than 8 years gynecologic age, we have to use high resolution 8 megahertz probe to diagnose PCO morphology, and they revised the number of follicles for diagnosing PCO per ovary and changed it from 10 follicles per ovary into 20 follicles per ovary and or ovarian volume of more than 10 cubic centimeters. So this is essential modification to restrict over-diagnosing patients with PCO in the age group of adolescency, because they excluded women with 8 years gynecologic age and even more than 8 years gynecologic age. We have to use high resolution 8 megahertz probe and 20 follicles per ovary in addition to ovarian volume more than 10 cubic centimeter. In the 8-year gynecologic age, multifollicular ovaries are common, which represent few cysts less than 6 or more than 6 per ovary, which tend to be larger up to 10 millimeter in diameter and distributed throughout the ovary with no stromal hyperechogenicity or hypertrophy. This is not similar to PCO morphology, which is 8 or more subcapsular follicular cysts around 20, less than 10 millimeter in diameter, with increased stromal echogenicity by ultrasonography and or ovarian volume more than 10 cubic centimeters. They clearly stated that pelvic ultrasonography is not recommended for diagnosing PCO within 8 years post-menarche, so don't forget this important sentence. Regarding anti-Mullerian hormone, they recommended that anti-Mullerian hormone levels are not recommended for PCO diagnosis generally, and of course in adolescent PCO. So don't ask for anti-Mullerian hormone requests for investigation. It's a very expensive test and adds no value for the diagnosis. PCO is a diagnosis of exclusion, so please consider other disorders that mimic PCO that may lead to clinical hyperandrogenism or this sonographic appearance or irregular cycles in this age group. But some of us will say that I am sure that this case is PCO, but the biochemical hyperandrogenism is not present, or the sonographic morphology is not fulfilled in this case, and I am confident that this is a case of PCO. So if you see a case with PCO features but not meeting the diagnostic, does not mean meet the diagnostic criteria for PCO, this is called at-risk adolescent. And actually this case should be put in focus with appropriate symptomatic treatment and regular re-evaluation to be sure that this is a case of PCO later on by clinical hyperandrogenism, biochemical hyperandrogenism, or PCO morphology by ultrasonography. Adolescent patients with criteria of PCO should be screened for anxiety and depression manifestations and eating disorders. Actually, it is a multidisciplinary model of care including health psychologists, gynecologists, dietitians, and endocrinologists. Okay, I diagnosed the case of adolescent PCO with menstrual irregularities with clinical and biochemical hyperandrogenism and PCO morphology by ultrasonography. What is the first line of treatment of this case? The first line is healthy lifestyle intervention, and this is the first and important line of treatment, including weight maintenance, avoidance of weight gain by diet control, physical activity, and exercise. So it is a multi-component including diet, less sedentary life, exercise, and behavioral strategies. Diet control means low glycemic index diet, low carbohydrate, ketogenic diet, and increase consumption of ample amounts of vegetables, some fruits, vitamin D, calcium, and herbs. Not all cases of adolescent PCO are obese. Around 20% of them are lean, so don't be confused by the weight of your patient or the appearance of her as a lean growing female, because 20% are lean. And in such a case of lean PCO, the mother will tell you that she is very thin and her weight is 45 or 50 kilograms. How to make diet control? Diet control in such a case is not weight loss, but a variety of nutrients, minerals, and vitamins. A common mistake of the patients that when you order them to have exercise, they mention we are moving, we are going to work, and so. And moving at home or going to work is called physical activity, which is any body movements produced by skeletal muscles that require energy. And the physical activity for the adolescent is a minimum of 60 minutes per day, moving most days of the week, moderate to vigorous intensity. But this is not synonymous to exercise. Exercise is muscular strengthening activity requiring physical efforts carried out to sustain or improve health and fitness. So exercise is different from physical activity, and for adolescent patients or women, the exercise is performed at least 3 times per week, and we have to instruct our patients that you should have good physical activity every day, nearly every day, and you should have exercise nearly 3 times per week. And this is recommendation by the International Evidence-Based Guideline for Assessment and Management of PCO. The HRSRM recommendations mentions that for symptomatic management, COCs and or metformin may be beneficial. COCs are prescribed to patients with adolescent PCO to regulate cycles and to treat hyperandrogenism, as it leads to suppression of ovulation and decreased androgen production. The mechanism for hyperandrogenism treatment is inhibition of gonadotrophin secretion, increased sex hormone binding globulin, decreased serum total and free testosterone concentration. Some secondary mechanisms including decreased adrenal androgen secretion, inhibition of peripheral conversion of testosterone to dihydrotestosterone, and inhibiting its binding to the androgen receptors. Since we are prescribing COCs to treat hyperandrogenism, we have to avoid COCs containing most androgenic progestogens, which is levonorgestrel, and typically you have to choose the products containing low or neutral androgenicity like norethindrone. Some clinicians prefer to start with COCs containing an anti-androgen progestins like drospirenol or ciprotron acetate, and drospirenol is a weak anti-androgen structure related to spironolactone with a possible excess risk of venous thromboembolism. So selection of the type of progestogen is very important. Avoid androgenic progestogens, use low androgenic progestogens or anti-androgenic progestogens. Ciprotron acetate works by decreased ovarian androgens, inhibition of steroid receptor complex, and decreased LH secretion. And spironolactone and drospirenol is similar to spironolactone, or a derivative of it, is an aldosterone and androgen receptor antagonist, inhibiting steroid receptor complex and inhibiting transfer of androstenedione to testosterone and subsequently to dihydrotestosterone. What about role of metformin in patients with PCO? At least 20 randomized control trials, one of them included adolescent patients, found beneficial effects of metformin on the body mass index, waist to hip ratio, and the triglyceride levels. Is metformin essential for adolescent lean PCO? As I told you, around 20% of PCO patients are lean, so why to give them metformin? This is a good question from the parents. It has been found that metformin use was more successful in restoring menstruation and ovulation in lean women with PCO, with significant reduction in fasting glucose, testosterone, and insulin resistance than obese patients. So it is very beneficial, and we have to inform the patient and her parents that this is not a treatment of obesity, rather than treatment of hyperinsulinemia and insulin resistance. And there is no change in body mass index and waist circumference in both groups as found in this study. It has been concluded that treatment with metformin 1,700 milligrams daily was more effective in lean than in obese women with PCO. Its efficacy was independent on the initial surrogate markers of resistance to insulin. So the different lines of management of adolescent PCO can be shown in this algorithm for lean PCO and can be used also for obese PCO, including number 1 is lifestyle modification, number 2 metformin, number 3 COCs for treating hyperandrogenism and restoration of regularity of menstruation, and anti-hirsutism, anti-acne in many cases. What about surgery? There is no role of laparoscopic ovarian drilling in adolescent PCO at all. It is used for induction of ovulation in patients with failed clomiphene citrate, letrozole, induction of ovulation in maximal doses, and it is similar to HMG treatment or FSH treatment in infertile women. But for adolescent PCO, just doing surgery is not recommended at all. In conclusion, I would say that adolescent PCO requires adherence to the international society's recommendations and guidelines to avoid over or under diagnosis. Over diagnosis is not good because you may give your patients a lot of treatment unneeded, and under diagnosis is not good because the PCO syndrome is an endocrinal disturbance that may lead to long-term complications like metabolic syndrome, cardiovascular disease, diabetes mellitus, and if you ignore this disease, you may expose your patients to these long-term complications. If you like this lecture, please don't forget to press on the like icon, and don't forget to press on the subscribe and notification icons to have more lectures. And thank you very much. Bye bye.